I was born in Italy in a very small town. I was almost 15 when I came to Canada. I've been here in Sudbury for about 62 years. I have been a diabetic now for 59 years. I was 17 when I first diagnosed. I was lucky. I met the right man. He's been good to me and he's been helping me through the years. As I got older, my lows became worse. I had them maybe more often. I didn't have any symptoms that they were coming. One time when I went out, I went to this grocery store to do my groceries, and I was walking down on the aisle, and all at once, I don't know what happened. I didn't know where I was. I didn't know what I was doing. Thank God I found the juice and I had some juice. And after a little while, I finally realized where I was. Things got worse. I started being afraid of going out. I didn't want to go out. I tried to protect myself the best way I knew. And I started staying home. A little bit later, when I finally had the Dexcom G6 introduced to me, I was amazed that I knew every second how my sugars were. I started feeling more secure. I started feeling free, a big weight taken off my shoulders, and I started going out. And I started having the freedom that I used to have before when I was younger. And it felt good. When I'm outside now with the Dexcom G6, it warns me before anything happens. I can do a lot more things than I used to do because I know that now I do have something with me all the time to tell me when there's a problem coming. My A1C it's the lowest it's ever been, and it's a good number, so I'm happy with that.
Hello, and welcome to the Industry Auditorium. My name is Joanne Lewis, and I'm the Executive Director of Healthcare Provider Education and Engagement at Diabetes Canada. I'd like to welcome Dr. Ilana Halperin. Dr. Halperin is a staff physician and endocrinologist at Sunnybrook Hospital in Toronto, where she leads quality and innovation in the Division of Endocrinology. She is also an assistant professor at the University of Toronto. Today, Dr. Halperin will be discussing how to implement the 2021 Diabetes Canada guidelines for glucose monitoring and how to support patients in the initiation of RealTime CGM soon after diagnosis. Before going any further, a special thank you to the sponsors of this session, Dexcom, and a reminder to all of you to put your questions in the Q&A box throughout the session, and Dr. Halperin will be available to answer those questions immediately following her presentation. Without any further delay, over to you, Dr. Halperin.
Thanks everybody for joining me this afternoon as I take you through a 20-minute practical guide to continuous glucose monitoring evidence and the updated Diabetes Canada monitoring guidelines. Just a disclosure here that, data is changing all the time, and this is Dexcom is doing its best to keep things true and correct. And here are my disclosures. And so by the end of this 20-minute session today, we're hoping that you'll walk away feeling more confident, having conversations with people who maybe you wouldn't have thought about using real-time continuous glucose monitoring with before. And navigate some of those factors that might affect the timing of a real-time CGM start. So just as a reminder for this audience, we're talking about two major types of CGM. Real-time CGM, which comes out with continuous glucose monitoring, pushing the data forward to devices such as an application on a smartphone or a smartwatch or an insulin pump, and the intermittently scanned CGM, which require the user to scan at least every 8 hours to get full continuous data, but you can scan as many times in a day as you like to get a glucose as well as an arrow. Again, always good to stop and think about the modernization of glucose monitoring. And we'll start with the capillary blood glucose. 4 glucose values here that all seem in range, but the A1C is not quite a target. Why might that be? Well, because there's quite a bit of highs and lows that are happening between those 4 glucose values. And again, a reminder here that with intermittently scanned CGM, to see this whole profile, you have to remind your patient to scan at least 3 times a day. I usually say at least when you wake up, before dinner, and before bedtime. And we know that if people sleep for more than 8 hours, we will have a small gap in those numbers, but I rarely ask someone to wake up to scan their glucose. But what if we introduce real-time alerts and alarms? Well, that might actually help to flatten out that curve. Patients are alerted to the fact that their blood sugars are going high, and depending on what therapy they're on, they might adjust their therapy, or they may just go out for a walk to help to curtail that hyperglycemia after a big bowl of pasta. And as well, what if they're starting to drop low after an insulin dose that wasn't quite appropriate for the dinner they had? Well, an alarm that's letting them know that in the next 30 minutes, they're going to be below 4.0 might help them to consume some carbohydrates and prevent that hypoglycemia from happening. Let's take a look at what the 2021 Diabetes Canada monitoring guidelines say and the levels of evidence around CGM use. So for real-time CGM, adults living with type 1 diabetes of all ages, there's strong grade A, level 1A evidence for decreasing A1C, increasing time in range, decreasing hypoglycemia, with some evidence to suggest improved quality of life and treatment satisfaction. In type 1 diabetes adults with impaired hypo-awareness, there's also good evidence that they should use real-time CGM for the decreased hypo incidence and severe hypoglycemic events. What about type 2 diabetes? Probably not thought of as much when it comes to real-time CGM, but we do have randomized controlled evidence to suggest that they will benefit from the use of real-time CGM with alerts and alarms as well, for decreasing the A1C, as well as decreasing the time spent in hypoglycemia. However, we know evidence is moving very quickly. And so there's been 3 trials I'm going to talk to you about today that came out after the 2021 glucose monitoring guidelines were completed. So let's practice the guidelines with some cases that you might encounter in your clinical practice. And I want you to think about these 4 different cases and of these people who should be using real-time CGM. The first is a patient with type 1 diabetes who was diagnosed just 3 months ago, managing with basal bolus insulin injections and having sporadic hypoglycemic events. So what should we discuss in our conversations about real-time CGM for this individual? We know, depending on where you are in Canada, there are some criteria around when you can start insulin pump therapy, but there is no criteria about when you can or cannot start real-time CGM. And so as we mentioned before, this person would fall into the should use real-time CGM category, and we'll show you why. And this prospective observational study where they looked at people who were diagnosed and looked at the difference in the A1C based on when real-time CGM was initiated, you could see that in those that had their CGM initiated within the first 6 months of diagnosis, there was a significant and sustained improvement in their A1C relative to those who had CGM delayed and not initiated until 2 to 3 years. And those who continued to remain off CGM continued to have higher A1Cs relative to those who had the CGM initiated around 2.5 to 3 years. And so we can see sustained lower A1Cs for up to 7 years when real-time CGM is started soon. And you can think about how critical the education is, people learning to live with diabetes in those first 6 to 12 months after diagnosis, and what a powerful tool, and especially around preventing that fear of hypoglycemia. The first hypoglycemic event that someone has after initiating insulin can dictate what's going to happen with their relationship with insulin and their diabetes management for years to come. And so having that support and protection against hypoglycemia early on in the diagnosis is probably really important. So I was really lucky to work with a fantastic medical resident who helped me put a lot of my thoughts about how we can use the data from glucose sensing technologies to really help our patients live better lives by decreasing their glycemic variability and improving their time in range. And so especially for those new starts who are earlier in their diagnosis, the data that they can get day to day, as well as the data that you can get from looking at an ambulatory glucose profile, and having a useful clinical conversation with them can be really meaningful. One of the things that we really have to teach patients, and sometimes we have to teach the patients who are been on insulin for a longer time, this even more so than our new diagnoses, is that they need to be patient with insulin action. If they inject the insulin at the same time that they start eating, they're going to find that their glucose spikes before the insulin kicks in. And if they don't know that, then the data from the CGM could actually be dangerous because they go, oh no, 2 arrows up, I'm spiking, I better take more insulin. And what that leads to is the so-called insulin stacking phenomenon. And so my first 2 points here about being patient and pre-bolusing are really critically important to helping to flatten out that curve, as we were showing earlier. The next one is more about nutrition and recognizing that no amount of insulin can kind of counterbalance a regular Coke. And so when we need to sort of work with our patients about understanding that we want to support all different, patterns of eating, but a lower glycemic index and lowering the overall amount of carbohydrates taken at any given meal and making sure it's balanced with fat and protein. I've learned that from my dietitian colleagues, and it's really helpful to my patients. The fourth thing I noticed a lot of us do as healthcare professionals and people with diabetes is we're more comfortable titrating up basal insulin than we are adjusting bolus insulin. And so sometimes when you look at the AGP, you see how patients really drop overnight. And if you ask them, what happens during the day if you don't eat for 5 or 6 hours, and they say, oh, I start to go low, and they have to constantly be snacking, that's like being over insulinized, and you're sort of feeding your insulin, and can also lead to quite an epidemic of weight gain in our patient population or those with type 1. And so that's another thing that the CGM and looking at those insulin metrics, not just the CGM metrics, about how much basal and how much bolus insulin can really help you give your patients more useful advice. And then the ones that I often say to the patients is to think about your arrows and remember that your arrows on a CGM device tell you where your glucose is going to be 30 minutes from now, which is when your insulin is going to start to work. So it's possible that when you're starting to dose for a meal, if you've got 2 arrows going up, you know that your glucose is on its way up and you can take a little more insulin safely in order to prevent that spike from getting even higher. And I always encourage the patients, and the Dexcom Clarity app does a great job of this, reflect on your data once weekly and aim for small wins, because every 10% change in your time in range is equivalent to a 0.5% lowering in your A1C. So let's talk about our next patient. Somebody who's been managing well with an A1C in range for the last, since she was a child, on insulin pump therapy. What should we discuss in our conversations about real-time CGM for her? So again, she certainly falls into the category of should use CGM, but maybe she's using intermittently scanned CGM and happy about it and feels she's managing well on it. But in the ALERT study, we learned that people who have been using the Libre for 2 or more years and are switched to Dexcom G6 had a lower A1C, improved time in range, and decreased fear of hypoglycemia. And you can see that even the difference between having the sort of data pulled versus pushed to you can really make a difference. And this is just in a regular patients with type 1 diabetes population. We're not even talking about automated insulin delivery here, which obviously can really help people to improve their time in range and decrease their hypoglycemia. But just by introducing those real-time customizable alerts and alarms, you can see that they improve their time in range as well as a decrease in their time spent in hypoglycemia. And so we are again reminded of who should be using real-time CGM. An important tip is to encourage people to set useful alerts and act on those alerts. And I often remind my patients that they can go into their settings and adjust their alarms up or down, depending on what's happening in their time right now, and decide which of these would be helpful. Some of them are a little much. If you have every single alert turned on, it's easy to get alert fatigue and stop acting when your CGM goes off. But the ones I focus on is the urgent low soon, and choosing a low and a high alert that makes sense for the patient. Here's an example of the urgent low soon alert and why it's so important, because it can prevent people from actually spending time in hypoglycemia. And here you can even do the repeat on the high alert, which I think is really helpful for patients, because the first high alert might not be something you want to act on, especially if it's just an hour after you've eaten and taken your insulin. But the repeat, you can choose how long after the repeat alarm goes off. And if that goes off, maybe that's when you would consider giving yourself a correction. So let's move on to type 2 diabetes. What should we discuss in our conversations with this population? We might have an individual who's on basal insulin only recently added, or somebody who's recently had to add bolus insulin to their regimen. So as I mentioned before, the 2021 Diabetes Canada monitoring guidelines did suggest that we may use real-time CGM in type 2 adults who are on a basal bolus insulin regimen and not yet meeting their A1C targets. And we can imagine how that could be helpful. But the Diabetes Canada guidelines didn't really touch on a huge population that we deal with here in Canada, which is adults with type 2 diabetes on basal insulin alone or with other non-insulin agents. So this study, the MOBILE study, came out after the Diabetes Canada evidence review was completed. But what we found was in adults who are already managed with basal insulin in primary care and started on a Dexcom G6, compared to those who were not, they had a significant improvement in their A1C time in range and time above range, with the time in range increasing by 3.6 hours per day. And when they discontinued real-time CGM, unfortunately, the gains in that A1C and time in range were lost. So we often talk about using this as a tool, a teaching tool. I do that all the time when I suggest maybe somebody who's new to the diagnosis could benefit from using an intermittently scanned CGM. But what we're learning here is that this sort of biofeedback and behavioral interventions of, oh, your blood sugar's going high, maybe that means you should go for a walk, or, oh, your blood sugar's going low, so maybe you should do something to prevent it from getting lower, and then you can still feel confident about titrating your insulin overnight. These are things that can't just be done intermittently. We need to continue wearing the device to see the improvements. But if they continue the Dexcom, that gains in A1C and time in range were maintained. So here's a great example, and I love these examples as things that I explain to my patients in practice, and then when they get to have it in their, experience it in their real life, it's such an aha moment. I thought my granola and banana was a healthy option. But when I switched to peanut butter toast and some berries, look at what a difference it made for that early morning postprandial blood sugars. And these types of learnings can be really powerful for our patients to feel like they're in control of managing their diabetes. It can also help them to learn about the impact of physical activity. Here's Saturday looking at what happens to the glucose after sitting at the desk all afternoon. And then an hour and a half after lunch going for a walk. Wow, a walk can really help to bring my glucose down. But of course, if I walk right after lunch, it doesn't even rise to begin with. And the patient thinks, I didn't even think that was possible. And so this could be someone who's just on basal insulin and can still have a lot of control with their postprandial hyperglycemia just by making certain dietary and physical activity choices. So of these people living with diabetes, who should choose real-time CGM? You know, it's still a question about the basal insulin recently added patients, but I think that the MOBILE study and increasing coverage for real-time CGM will see a growing place for this device to be used across all the different populations of diabetes. So now, you know, what's the biggest barrier to patients not being put on real-time CGM? If it's not offered to them. And so we need to reflect on some of the factors that influence real-time CGM initiation and what are our biases as healthcare professionals when we think about who would benefit from the products. So now that I've hopefully convinced you that Diabetes Canada guidelines and the evidence that's come out since those guidelines were published, supports the use of CGM in all four of these patients, let's think about what assumptions we might make as healthcare practitioners that might prevent our patients from accessing these devices. So the first patient with the new diagnosis, you know, maybe he's not done any post-secondary education and doesn't have any private insurance coverage. So is that a reason not to offer the device? And what about our next patient who's been managing well with her insulin pump and her intermittently scanned CGM? We could make the mistake of assuming she's too busy to learn a new device. And our older patient who's just started on basal insulin, might she be too nervous to rely on technology? Or the new individual who's just getting over the idea of having to inject insulin more than once a day, who probably wouldn't want a device on his body. So there is actually a growing body of evidence about provider bias and assumptions regarding technology, and how there can be a big gap between what the person living with diabetes thinks in terms of it being a barrier to starting on CGM technology versus the clinicians. So while 35% of people living with diabetes may not like devices on their body, clinicians assume that that's closer to 60 to 70%. And people living with diabetes, a small percentage, less than 20%, admitted to feeling nervous relying on technology to help manage their diabetes, whereas clinicians assumed that more than 30% would be nervous about technology. Again, people living with diabetes are not that generally too busy to learn a new device. It's a very small percentage, but clinicians assume that that would be higher. And what's really important is that people with diabetes can figure out how these devices can help them to manage their glucose without a lot of input from the clinicians. But the clinicians assume that they won't know what to do with the information. And I think a lot of the studies that I've presented today showed how ongoing use of real-time CGM can provide that sort of biofeedback necessary to make adjustments to your medications, your food, and your activity to improve your glucose ranges. And that we really need to change our perceptions and check our assumptions around the gaps for the use of technology. And we should be careful not to assume that the cost or a high level of education is required, as many people can find these tools and technologies useful. And this is some data from the US that shows this very nicely. And we can see, the 3 different populations and the A1C. Everybody has a nice blip in their young adult years, but it's differentially worse in Black, non-Hispanic Americans, seconded by the Hispanic or Latino, and then the white non-Hispanic population having sort of the best A1C control throughout lifestyle. And the question is that a systemic problem related to access to technologies, access to coverage and cost of medications, or is it actually in some ways related to the bias? If we take out of that 15,000 person study, the 4,000 or so people who were using CGM, you can see how the gap really narrows. And so the CGM can actually be really helpful at closing some of those gaps if we're able to overcome our own biases and ensure equitable access. And that is obviously not only in the control of the healthcare professional, but even if there could get access through public or private insurance, if it's not talked about in the clinical encounter, then it's unlikely that it's going to get used. You can see, again, the disparity still in terms of that CGM use across the different groups. So one of the biggest barriers I think that we are all sort of at fault for is assuming that coverage is the issue. But the coverage is really changing rapidly across the country. And a lot of private insurers are now covering real-time CGM for those on insulin. And so it's really important not to assume that there won't be coverage for real-time CGM, and to work with your patients to try to see what they are eligible for because of all the benefits that we've seen already. And this map just shows all the different places where there is some provincial or public coverage. And obviously the criteria vary across the country, but hopefully you'll become familiar with how you can help your patients get access to this technology, either through private or public insurance after this talk today. So I hope that I've given you some food for thought, and you might feel a little bit differently about how you might discuss real-time CGM with these different types of people that you'll see in your clinical practice today. And hopefully you'll walk away feeling more confident about using the Diabetes Canada glucose monitoring guidelines and the emerging evidence that has come out since then to guide your conversations about real-time CGM with people living with both type 1 and type 2 diabetes. And reflect on factors in your practice, including your own potential biases that may affect the timing of a real-time CGM start. Thanks so much for joining me today, and I look forward to seeing you later this evening.